See, got it there. So I made it somewhat brief and sort of basic for my presentation, and thinking that there might be more clinical questions from the participants tonight, and I'm happy to answer them as we go through. Sometimes I find those are more relevant and more helpful than going through sort of the written information that's on my slides. So whenever you have a question, jump in and I'm happy to answer. So we'll talk about Raynaud in general and a little bit of sort of specifically in scleroderma. Um, oh, so our objectives tonight, I'm hoping to review sort of epidemiology and clinical presentation of Raynaud, and then I'll just touch on some of the mimickers of Raynaud that's outside of our diseases that we deal with. I'm going to try to differentiate the primary and secondary Raynaud, and then we're going to understand sort of the diagnostic evaluation process that I usually do with the patients. And then we'll sort of go through some of the therapeutic options we have for Raynaud patients. So overview, we know that the Raynaud is sort of the phenomenon that is a transient peripheral vasoconstriction that is in response to cold exposures or emotional stress or persistent vibration. And most experts agree that at least two or at least biphasic changes in skin color is required for the diagnosis. That means typically there are sort of what we call triphasic is a very classic Raynaud. Triphasic going from white or pale when you're sort of exposed to the cold, that is sort of acute vasoconstriction phase. And then it goes to blue where you're seeing the cyanosis, which is sort of a low oxygen status in our tissue, followed by redness or the sort of purple redness, which happens during the reperfusion states when as you're warming up, the blood comes back to the fingers and it goes to more red and purple. So the classic Raynaud is often described as triphasic. Having said that, everyone's different and everyone presents not classically, right? So we see a lot of aclassic or atypical or not very classic cases. We would say that at least the paleness and possibly plus minus sort of a blue face, so biphasic is required for the definitive diagnosis of Raynaud. And the prevalence in epidemiology, depending on where you're studying, what sort of gender you're studying in, it varies a little bit. Obviously, if you're in an environment where it's more colder, you probably see it more often. It's if you're looking at people that are more younger with the female more in that group, you'll see more. And also the certain work exposure can increase the number of Raynaud. But in general, most population-based surveys kind of estimate Raynaud to be anywhere between 3 to 5% in general. And that's kind of all comers, whether it's a primary Raynaud or secondary Raynaud or any type of Raynaud. We know that Raynaud occurs more frequently in women, and especially in the younger population, so in their teens and in their 30s. And in patients who has the family history of primary Raynaud, there is an increased risk of having a primary Raynaud, and they often happen in young female population. When we're looking at the gender distribution, it's often described as sort of 9-to-1, 8-to-1, with female being a larger proportion. So, I mean, I think many of the patients or participants today probably have seen it or have it. So clinical manifestations are that, as we described, the changes in the skin color, whether it's the paleness or the blue or purple or the redness or a combination of those. It usually affects the extremities most commonly, so fingers and toes, but it can involve other areas as well. And people may not realize it, but some people get it in the ears, knees, or even nipples. So any areas where it's sort of thought to be extremities, okay, not the core body essentially. Sometimes the patients can also develop pins and needle sensations or numbness or finger pain associated with these Raynaud attacks. And in severe cases, what we are more concerned about is really this kind of ischemic complications. So the digital ulcerations of the fingertips and toes, and then eventual gangrene or sometimes loss of the digit. And often some of these patients lead to self-amputation of the fingertips. And so those are some of the more severe complications. And as you can see in here, so that's kind of the typical paler. Can you see my pointers on the slide? Okay, so the first picture here, there you go. Yeah, the first picture is kind of that paleness of the Raynaud that you see. And then these two fingers are more, severe cases. We're starting to notice this necrotic fingers or gangrene in the fingertips. And certainly as these get worsened, some people develop self-amputation, meaning the shortening of the fingers. So we'll touch on a little bit about mimickers of Raynaud, because when I ask patients about, does your hands change color in temperature changes or cold exposure, there are other conditions that changes the color of the hands and feet that are not Raynaud. Not limited to these ones, but some of the common ones or some of the ones that we encounter are some of these things. So erythromelalgia is a rare condition, and the picture A and B, that's kind of the typical picture of erythromelalgia. And it's a condition where patients develop this almost red hot. They don't go pale or blue, but it goes very red. And typically in exposure to warmth. So after a hot shower, typical history is that, after a hot shower, they get out of the hot shower and then develop this kind of really, really red hands and feet. And this is sort of similar to Raynaud in that it can be primary or secondary. So primary means that it happens on its own without any associated underlying disorder. Again, this one typically happens in young patients, and not any disease, but sometimes there is a little bit of a genetic factor. So people who's got family history. It usually kind of resolves on its own once the temperature changes. And there are secondary erythromelalgia, which is associated with a whole bunch of conditions potentially. So infection sometimes endocrine metabolic disorders. So that's things like thyroid disease can be associated, or sometimes hematologic malignancy or hematologic abnormalities. So blood cell abnormalities, or blood cell cancers or lymphomas. Acrocyanosis is sort of this picture right here, where you're seeing the blue or gray changes in the toes and fingers. It's essentially a lack of perfusion to the tissues, and often associated with either cardiac disease or sometimes pulmonary disorders. And it leads to sort of it leads to vasoconstriction, so constriction of the blood vessels, leading to lack of tissue perfusion or lack of blood flow to the tissues, and it turns into sort of blue color, but it doesn't have that paleness that's associated with Raynaud. Occlusive vascular disease are things that just means that there's some sort of blockage of the blood vessels, whether it's the blood vessel problem or sometimes the clotting disorders or congenital abnormalities. So it just leads to lack of blood flow to the fingers or wherever the sort of tissue. And then the last one is called complex regional pain syndrome. This one right here is that. So you can, it's sort of it's a rare condition where patients can develop this atypical pain and sometimes sensation changes to most often extremities, either hands or feet, and could be triggered by some sort of injury. And typically the hand or feet will go more like purple or red discoloration, but diffusely. So typically in Raynaud patients, there is a clear line where it's normal and abnormal. So it's typically involving the fingertips in Raynaud, versus in complex regional pain syndrome, it's usually the whole hand or whole feet. And the whole thing goes kind of red, but also patients have sort of exquisite tenderness that develops in these areas. And sometimes the skin itself will become shiny and they'll lose hair on that area. So all of these kind of combination of the symptoms lead to a diagnosis of complex regional pain syndrome. So some of these are sort of the mimickers of Raynaud. So when we see patients with someone who comes to me and says, oh, my fingers or my toes or hands change color at times, these are some of the things that we would think about in addition to Raynaud on our sort of possible list of things to consider. And sort of going back to Raynaud now, so I kind of quickly mentioned it earlier. So there is a primary Raynaud and secondary Raynaud. That's how we kind of group them together. Primary Raynaud means that there's no evidence of an underlying disorder. It typically happens in young female, but can happen in sort of older, or sorry, can happen in male. I would say it doesn't typically happen in older people. And usually nail fold capillaries are normal. Fold capillaries are these little blood vessels at the fingertip. So right under these nail, there is tiny little blood vessels that we try to look at with magnifications. Those are normal in these patients, and it's usually not associated with digital ischemic injuries. So the primary Raynaud patients don't usually have the ulcers or gangrene or that sort of thing. So most often it's a bit annoying for these patients because it happens in cold and it kind of limits their activities outside of the, outside in cold, skiing and that sort of thing. But it doesn't usually lead to ischemic injuries. And it doesn't mean that it's usually not associated with any underlying disorder that needs to be treated. Now, the secondary Raynaud is what we see in scleroderma patients. So secondary Raynaud means that there is underlying disorder associated with it. And often these patients will have abnormal nail fold capillaries and some other abnormalities either on the physical examination or investigations. And these are some of the causes of secondary Raynaud. So quite a broad different things that could be associated with it. Obviously, connective tissue disease being one of them. So connective tissue disease means things like scleroderma, lupus, Sjogren's, myositis, but also some of the other autoimmune diseases can be associated with Raynaud. Not as common, but sometimes patients with psoriatic arthritis, sometimes can have Raynaud, not as commonly as scleroderma, the connective tissue disease or scleroderma. Drugs, there are certain drugs that can be associated with it. I won't go into details, but some of the cardiac medications, so beta blockers that patients are on sometimes for their heart rhythm control or blood pressure control, sometimes can be contributing to the Raynaud. The other thing that kind of falls into this category, it's not actually a medication, but smoking or cocaine, those things can also increase the Raynaud or potentially cause Raynaud. So those are some things that we ask. So when you go to doctors, they always ask you about smoking history, whether you do any drugs or alcohol, all that questions. So there is a reason for those questions, and often that's why we screen for these things. The other thing is not many patients know about this, but overt vibrational exposures can cause Raynaud. So people that work in mostly people that work in construction with those vibratory machineries, and if they have exposure to that for a prolonged period of time, it could actually induce Raynaud in their fingers. And other things like obstructive vascular disease. So if they have stenosis, meaning narrowing of the blood vessels that are going to your hands or your fingers for various reasons, that can contribute to Raynaud as well. Certain infections can sometimes be associated with Raynaud. Things that come up more commonly are things like hepatitis infections or HIV infections, along with a whole bunch of other things potentially. There are other causes as well. These other causes probably are more rare, but things that could fall into that are some endocrine abnormalities. So hormone issues like thyroid disease can often be associated with it. So we've had patients that come into the hospital with new onset thyroid disease that's uncontrolled, and they would have really bad Raynaud. Once their thyroid disease get controlled, it got really, it improves dramatically. So those are some of the causes that we keep in our mind when we're seeing patients with Raynaud. And so particularly in Raynaud in scleroderma, we know Raynaud is very common in scleroderma patients. And some of the studies, if you look at the studies, they quote up to about 90 or over 90% of patients with scleroderma present with Raynaud phenomenon. Raynaud seems to be the most common first manifestation of scleroderma. And on average, it can precede the diagnosis of scleroderma 5 or almost 5, 2 to 5 years. So in limited scleroderma cases, average about 5 years. So Raynaud happens about 5 years before the diagnosis of limited scleroderma. For diffuse scleroderma, typically about 2 years before the diagnosis of diffuse scleroderma. And so when we see these patients for the first time, some of the causes and things like that, we have that in our back of our mind. And what do we do to sort of to assess for it? So first of all, history and physical examination by a physician is very important. We, ask you a whole bunch of questions that are pertaining to connective tissue disease, but also for a screening for infections, medications, your smoking history or drug use, family history, all of those things. And then the physical examination would be to look for any signs of any of these diseases that we have, diseases or any secondary causes that we have laid out there. And obviously, we would be looking for signs of connective tissue disease, scleroderma, as well as potentially any signs to suggest mimickers of Raynaud. And then the second part of it would be investigation, including blood work. So usually we do a whole bunch of blood testing. Usually I look for blood counts to look for any, hematologic abnormalities. We would do serologies that are important in autoimmune disorders. So connective tissue disease screening serology, things like ANA and, rheumatoid factor and such. And I do include chronic infection workup. So things like hepatitis B, hepatitis C, HIV, those are commonly included in our evaluation. We would often include urine analysis and kidney function and liver function to look for, as well as often thyroid disease or screening for thyroid disease and diabetes as well. I would say that's kind of the common blood work investigation we send out for someone who comes in with Raynaud. The other things that we do in evaluation is something called nail fold capillary assessment. So that's again going back to these, nail blood vessel abnormalities. And we often use what we call dermatoscope. So you might have seen us rheumatologists holding those little handheld dermatoscope, which essentially increases the magnification, looking at the nails, trying to look for the blood vessel abnormalities. And lastly, we do sometimes consider imaging studies. I would say I don't use this, I don't do it routinely because I don't think it would change our management. I do consider imaging studies such as CT angiogram or conventional angiogram, which are to look for blood vessel structures. So I usually do this in more severe or refractory cases to look for, is there any structural abnormalities like narrowing of the blood vessels or clots or something like that we're missing. And maybe that's why they're not responding to medication. And then number two, the other thing that some doctors are starting to do is to do the CT angiogram with the vasodilator medication during the CT angiogram. So they'll see what your blood vessel looks like before you're getting the medication and after you're getting the medication to compare and to see if there is any response to the vasodilator medication. So if your blood vessels are opening up to the vasodilator or not. And that could give us some idea as to how severe the disease is and how likely the patients will respond to the medication. Um, okay, someone asked about ANA testing, so ANA is sort of what we call anti-nuclear antibody testing, and that's one of the probably most common blood testing abnormality that can be associated with connective tissue disease. It's quite sensitive, meaning that I would say in scleroderma patients, typically ANA is positive, or studies suggest that ANA is positive in about 95% of the time. So it's very rare to have ANA negative scleroderma or lupus. So it will be a good screening test for scleroderma or lupus in patients with Raynaud, if we're sort of considering that as a possibility. So I just wanted to, we keep talking about nail fold and we keep looking at your nails and such, but you don't get to actually see what we're looking at. So I figure I put some, pictures here to show you what we're actually looking for. So this is your nail. And that's the nail bed. And these are little blood vessels that we're seeing in your fingertip. Just below the nail bed, essentially. And the normal patterns are like this. So what you're looking at is very thin, linear, and regular blood vessels all throughout. And in the patients with systemic sclerosis, we typically see this kind of tortuous and dilated loops. So these loops are much larger and much tortuous. Sometimes we call it giant loops when it's very big. These are some patients with dermatomyositis, and you're starting to see a lot of sort of abnormal looking blood vessels here. And sometimes we are starting to see these empty spaces between the blood vessels, meaning we're starting to lose some of the blood vessels in the fingertips. So these are some of the abnormalities that we're looking at. In patients with Raynaud with the normal nail fold pattern, they're probably more likely to be primary, whereas if they have these abnormal nail fold capillaries, that is helpful and is probably more I guess likely to be in a sort of connective tissue disease or autoimmune disorders. So someone asked about dermatomyositis. So dermatomyositis is another disease that falls in the connective tissue disease. So within an autoimmune disorder, there's a connective tissue disease, and connective tissue disease is another umbrella term for things like lupus, scleroderma, dermatomyositis, Sjogren's. So dermatomyositis is one of the connective tissue disease. They often present with the hallmark of the disease is that they have skin rash, but they also have an inflammation of the muscle. So they have an inflammation of muscle leading to significant muscle loss and muscle weakness. So that's a dermatomyositis. So now at Mary Pack, we have a machine called nail fold video capillaroscope. So it's this little handheld machine that's connected to the computer. And with this is kind of the picture I'm seeing. We can see nail fold capillary at much higher magnification than we can with the dermatoscope. So it can help in some cases where the diagnosis is still a bit of a mystery. And just kind of touch on why we are seeing this abnormal nail fold is because that in scleroderma, we think that the blood vessel lead to the disease status. There's a sort of correlation between the blood vessel abnormality and the scleroderma. And we feel that there is some role of blood vessel being diseased as a process of scleroderma pathogenesis. And so sometimes we see this is a blood vessel, and sometimes we're starting to see leakage from the blood vessels. And that's why we see some of these sort of what we call hemorrhage or almost bruising around the blood nail fold. And we see these enlarged nail folds sometimes. So just going back a little bit to the imaging studies, as I said, I typically consider this in more of a refractory cases that are not responding to the medication as expected. And it would be to assess for structural abnormalities. So in here, I guess you're starting to see, some of the narrowings, and you can see that it's not very perfusing in the fingertips. And then two, the response to the vasodilator medications, as I mentioned earlier. We'll touch a little bit on the management of Raynaud. So management, I typically divide into non-drug treatment and drug treatment. So non-drug treatment is, as we know, it's proven to be effective in patients that are in the mild sort of status. So obviously avoiding the cold exposure. So when I say avoiding the cold exposure, I always say it's important to keep the whole body warm. So it's not just your, fingers and toes that needs to be warm, but core body is important. The reason is that our core body senses the temperature changes and sends a neural signal to the periphery, your fingers and toes, to close down or clamp down on your blood vessels. So if your core body is cold, no matter how warm your fingertips are, it will cause a Raynaud. So core body, hat, keeping yourself warm overall is very important. And also avoiding a sudden temperature changes is also important. Sometimes it doesn't have to be that you're in a very cold environment. It's just that temperature drop again causes our core body to send a signal to the periphery and start clamping down. And then moving the body and exercising, and those are all very important, keeping your vessels healthy. Avoiding the triggers. So as I said, sometimes patients do have Raynaud secondary to emotional stress and vibration, as I mentioned earlier, and some of the aggravating medications. So if you can identify some of those triggers, and obviously avoiding them would be important. Smoking cessation is important, and that's one thing that you can certainly do to help your Raynaud as well as your vessel health. And then if there is any underlying causes for Raynaud, then obviously treating those underlying causes. So, if you have infection that's causing it, or thyroid disease that's causing it, or if there's a cancer that's leading to it, treating those underlying causes will improve Raynaud as well. Now we're going to move on to drug treatment and Raynaud phenomenon. Let's see, sorry. So someone, I'm just seeing the questions here. Someone says the hands turn purple even when she's working out and when her core is warm. Again, I mean, everyone's a little bit different, and you would have to, I would have to talk to, you would have to talk to the patient and investigate or evaluate to see, is there any other triggers during that time? Is there any sudden sort of temperature changes, or is there any sort of breezes, right? Even a quick breeze can cause a little bit of drop in temperature. And again, if you're working out, being very hot, and all of a sudden, if there's a little bit of temperature drop, maybe that causes the change in the finger discoloration. Again, hard to say without having to actually see and doing the evaluation. But so we're going to go through sort of first line and second line and some of the other sort of more refractory cases. So first line therapy, usually we start with the monotherapy, meaning one medication at a time. I mean, one, because sometimes mild cases respond to one therapy well, but two, also, we want to evaluate for side effects. So I don't want to start 2, 3 medications all at the same time. So typically start with one. Typically, the first line therapy is calcium channel blockers. So some of you may have been on it or heard about it. Things like nifedipine or Adalat or amlodipine, Norvasc or felodipine. Those are some of the calcium channel blockers we use. It is medications that are used for patients with high blood pressure. But what it does is that it opens up the blood vessel. It dilates the blood vessels. And so by doing so, it reduces the pressure in your blood vessel. That's how it works for the patients with high blood pressure, hypertension. But in our patients with Raynaud, because it opens up the blood vessel, it increases the flow to the flow of the blood vessel or blood to the fingertips and other areas. Other options that are not as much studied, but some evidence includes things like losartan and SSRIs. Sometimes we do use topical therapy, and I think that's helpful, especially if you have a couple fingers that are affected more than the other, or if someone is on some therapy and developing ulcers in one finger or something like that, or if their blood pressure can't tolerate. Obviously, as I mentioned, calcium channel blockers are they're used to lower your blood pressure. So sometimes patients' blood pressure can drop when you're on this medication, and that sometimes can be the limiting factor. And so if we can't bump up your medication that you're taking orally, sometimes using or adding topical therapy can be helpful. I put this picture here to kind of show you a little bit of the anatomy. So the blood vessel in our hand, so this is the pommel branch, pommel artery. And then from this artery branch, there's a small digital arteries that come off it and go to your fingers. And the digital arteries run sort of on the side of the fingers like this on your palm side. So when I prescribe topical nifedipine or sildenafil, I tell patients that you need to use it sort of on the base of your fingers on either side of the fingers where the arteries are running. And I don't usually recommend using it on the top of the fingers. The reason is often the blood vessels in the fingertips are already quite diseased and scarred down. And so there's not much of response to the medications in here. So we want to target the blood vessels that are relatively still healthy and will respond to the vasodilator therapy. So typically you could take a little pea size of sildenafil or a topical nifedipine or sildenafil and rub it a little bit on the basis of the fingers there. Another question here. So someone asked about, you mentioned sildenafil cream. What about oral sildenafil or tadalafil? So that's coming up. So that's more of a second line therapy. So typically the first line is calcium channel blocker. One, because it's studied more widely probably, and two, the cost of the calcium channel blockers are way cheaper than sildenafil and tadalafil. But in patients who are not responding to the calcium channel blocker or losartan or SSRIs, the second line would be either adding something as a combination therapy instead of a monotherapy, or a PDE inhibitor. So that's a sildenafil or tadalafil. And I say here, add topical vasodilators as well. The sildenafil or tadalafil, I think both are fine. Sildenafil tends to be a bit short acting, meaning you have to take it multiple times a day, whereas the tadalafil is a once-day medication. So it depends what you want. Some patients want, sildenafil or tadalafil just when you're going out for skiing or doing some activities or whatever, then short acting probably is fine. But if you're having multiple episode of Raynaud per day, then maybe having something long lasting like tadalafil might be more beneficial. Cost can be a limiting factor for some of these patients, but we do sometimes get a coverage, depends. Some cases we consider aspirin, not as widely, I would say. The other potential cause of Raynaud is sometimes clotting disorder. So things like antiphospholipid antibody syndrome. And so in those cases, we certainly would consider aspirin. There is a question about where do you apply the topical sildenafil cream on your feet and toe? I don't see it as often. So I find patients will notice more severely in the hands, and the ulcers developing more so in the fingers rather than toes. Ulcers don't develop as much in the toes. I'm not sure why, or maybe because there are more sort of the temperature is more controlled or warm in the because you more often cover your toes more than the fingers. But if you were to put it, I would say kind of similar, like just at the base as of your toes, um uh where the yeah, so it can be painful when you're skiing or when you're going out. Right now in the toe can be painful. Again, you could consider putting it and it will be more in the sort of at the base of the toe, just like your arteries run. So third line therapy, so these are patients with recurrent ischemic complications. So people who have that gangrene happening, or people who've had like almost self-amputation happening a few times, like that black necrotic lesions. Those cases, we want to preserve your fingers and prevent worsening of the necrosis. And in those cases, we sometimes add prostanoid, which is the what we call ibuprostanol or alloprost. These are IV medications and require hospitalization. And not just in regular bed. Often this needs to be in either ICU or high acuity unit in hospital. At least in Canada, that's the case. And the reason is because these are sort of a medication that require more frequent blood pressure monitoring, and so require more nursing support and monitoring in hospital. And so sometimes the logistically can be difficult because we have to find the bed and it has to be an ICU or high acuity unit and that sort of thing. But in those cases, we've had some patients being admitted for these things. In those severe cases, sometimes we add bosentan. Bosentan is another medication that can be used in patients with pulmonary arterial hypertension. So those with scleroderma, sometimes some of you may have heard about it. So it's a disorder where blood vessel that go from your heart to lung becomes affected by scleroderma and can narrow down and increase the pressure. And so in those patients, we use some of the vasodilator medication that opens up the blood vessel, kind of similar to what we use in Raynaud, but probably at much higher dosing. Bosentan is one of those medications. Now it's quite expensive and we don't use it as often for Raynaud. We use it more for the pulmonary hypertension patients, but in very severe cases, in refractory cases, there are some data, and so we've used it in some refractory cases. Having said that, the studies with bosentan show that it doesn't really improve your current ulcer, unfortunately, adding the bosentan, but it mainly acts to prevent future ulcers. So typically, if you have necrotic fingers and really bad ulcers, what's going to help is probably the IV EPO or iloprost during that time. So there's question about whether these topical creams or drugs would interfere with scleroderma renal transplant medication. I'm assuming the lung transplant medication. I'm assuming the lung transplant medication, you are referring to like immunosuppressive agents that you're on post-transplant. So probably like tacrolimus and MMF and that sort of thing. And my answer is no. Often we use those immunosuppressive agents for scleroderma patients for their lung disease and such, and adding these medications, we have no issues. And as I said, the medications that we use for Raynaud are often used in pulmonary arterial hypertension patients as well in scleroderma, and at much higher dosing. So the doses that we're using for Raynaud is much lower. And in very, very bad, like refractory cases, sometimes we consider surgical options or procedures. So these are cases that it's sort of something that I can't do, but send to surgeons locally. There's digital sympathectomy or Botox injection. Is kind of the similar idea, but what you want to do is when our body feels the cold temperature and sends a signal, you want to almost block out that signal to the fingers by either doing a nerve block or sympathectomy or Botox injection. Again, sort of a paralyzing that signal. The other thing that we've seen more recently, not often, but few cases, is something called arterialization of venous system. So what they do is, as I mentioned earlier, there's that palmar branch of the artery. And in Raynaud patients or in scleroderma patients, this digital artery are diseased by our scleroderma and there's lack of perfusion to the fingertips. But what they do is they take the vein system. So our blood go from artery to the tissue and vein back to our heart. But instead of using the artery, they flip it around so that our blood from our wrist go to the vein system and get perfusion that way. It's been done in few patients, not very often. So far, it's been successful in terms of outcome in some of the cases that I've seen. We have not seen long-term data, so it's hard to know what the long-term sort of outcome will be. And amputation is again, last resort, but sometimes needed, especially if there's been significant necrosis. Sometimes it kind of falls off on its own. If not, sometimes we do an amputation surgically. So another question. So I guess there was a blood clot. Someone had a blood clot many years ago, left with poor circulation, and sometimes gets a sort of a coldness in the toes and discoloration. I think if there is another reason for having poor circulation, I don't know if these a cream or the medication would be helpful. I don't think there is data, and also you would have to kind of weigh it out with the potential side effect of having low blood pressure and that sort of thing. And so in those cases, I probably defer to specialists who deal with more about blood vessel disorders, whether or a clotting disorder, and assess it that way. And sort of going back to the initial assessment of Raynaud, right? Or discoloration, and going back to what's underlying cause. And if the underlying cause is the connective tissue disease or some of our diseases, yes, some of these medication can help. But if the cause is something else, then I would probably, recommend treating those underlying disorders. So someone mentioned rituximab has been very effective with Raynaud and other scleroderma features. I haven't seen rituximab for Raynaud particularly, but it can be used in other scleroderma for other scleroderma manifestations. So we sometimes use rituximab for obviously interstitial lung disease or someone who's got worsening skin sclerosis. I don't know off the top of my head any data directly sort of studying Raynaud rituximab in Raynaud phenomenon, but I'll have to look it up. And calcinosis, so I put it there just because I think there's sometimes confusion between calcinosis ulcer and Raynaud ulcer. Calcinosis ulcer is different than Raynaud. So it's an ulcer that develops mainly from the mechanical protrusion or breakdown of the skin overlying the calcinosis. And some of these are the example of what you're seeing in calcinosis. Some studies say that in scleroderma patient with calcinosis, about 40 to 76% can develop ulceration at some point. So relatively common, those with scleroderma calcinosis. Now, we don't have clear understanding of why calcinosis happen in connective tissue disease or scleroderma. Some hypothesize that recurrent Raynaud or recurrent trauma, microtraumas, can contribute to calcinosis development. So something to consider, and I often recommend tight control or controlling your Raynaud carefully, especially if you have calcinosis as well, and trying to prevent recurrent sort of trauma to the fingertips or other areas that have calcinosis. The treatment of calcinosis and ulcer, so there's no proven therapy, unfortunately. Again, kind of focusing on Raynaud and prevention of trauma can be helpful. This is really severe calcinosis that you're seeing on X-ray. It's all over your fingers and hands and even on the forearms. And in severe cases, a surgical option can be considered. Having said that, it doesn't prevent any recurrence, and often patients will have recurrence on the same spot after surgical resection. So that's a bit of a limiting factor there. So that's kind of the end of presentation that I have, the slide that I have prepared. If there is any questions, I'm happy, or anything to comment on, I'm happy to have some discussions here.
Anyone have any questions? I actually have a question, Dr. Kim. Recently, I was on a call with some support leaders from in America, and somebody mentioned possible treatment for calcinosis using Tineret.
Oh, okay.
Have you know anything about this?
No, I haven't heard of it, but I think again, like calcinosis, I think there's been some stuff that are tried probably, but I'm not sure if there is like if it's been proven. Like I think the difficulty with these studies are that they're being studied, or there might be cases of success, but when you do it in the larger scale, often it doesn't pan out to be effective. And so I haven't heard of it, but I guess watch out for it.
Yeah, I know it was through the University of Washington. That's what I remember. The
Okay.
lady told me. Right.
Okay.
Okay, thank you.
Anyone else?
Dr. Kim?
Yeah.
Yes. Could you describe or show a picture of what like a finger, an ulcer looks like?
Sorry, what was that? Can you
Describe or show a picture of what a finger ulcer looks like.
Yeah, so let's see. I mean, let me see if I can go back and see if there is anything.
Like, is it black or what?
So it can, oops, sorry. So it can start with a little bit of little dots sometimes even, and then it opens up into more of a wet tissue on the fingertip.
Yes.
And then in severe cases, you'll see these kind of a necrosis, but that's probably more severe cases.
Okay, because I have a spot and it keeps draining on the end of my thumb with calcinosis.
Right.
And I'm wondering if that's an ulcer.
It could be. If it's open, I would certainly have, I think you should probably see someone and have it examined. And one would be to diagnose it, but also two would be to prevent having an infection over it, right?
And what do they do about that?
So again, if it's a calcinosis ulcer, we can't do much about it, but you would have to make sure that it doesn't get infected. So you don't want to have a secondary infection on the open wound. So it may lead to more of a wound care type of thing, or local antibiotic if needed. And then in the future, it would be more of a preventative therapy to make sure that you don't get recurrent calcinosis ulcers.
Okay, thank you.
No worries.
Hi, Dr. Kim. Could you ask, or could you answer if someone's using like a paraffin bath for your hands with the wax, would that help on an ongoing basis for helping with the circulation, or is it just a temporary relief?
Yeah, I don't know. I don't think there is any data to suggest that that leads to like more of a long-term benefit. I think it may certainly warm your fingers, and patients often have symptomatic benefit, I think, from those, but I don't know. To my knowledge, I don't think there is any long-term, because I think what's happening is in scleroderma, what's happening is there's fibrotic changes to the fingers and blood vessels, but paraffin wax or the external therapies may not really reverse or prevent those disease progression in the vessels.
Dr. Kim?
Mm-hmm.
I have had
full arm nerve blocks a couple of
Mhm.
times, and I'm just wondering what they're supposed to do. Do they have long-term benefits? Because I certainly have not had any with
Yeah.
that.
So it's kind of I think the analogy is as I was describing earlier. So, when our body feels the temperature changes, it sends a signal, but nerve block essentially blocks that signal to close down on your blood vessels, right? And so it's trying to maintain the blood vessels to be opened even when you feel the temperature changes or triggers. Having said that, I think clinically, I see some variable response. So I don't think everyone respond to that, unfortunately. So response can be variable. The other thing is the response, even in those who have response initially, it's not it doesn't last forever. So
No.
yeah, it can lose its effect even after the benefit.
And if you're, I've been on sildenafil for a very, very long time, 16, 17 years, and it is not as beneficial anymore. And so would you say it would be better to, I didn't realize that if you took it more often, that it was so short acting. It'd be better to maybe split up my dosage numerous times a day?
You can, I guess there's two things. If there is a little bit of response but not lasting enough, or you're requiring more, then yes, dose increase, or even a combination therapy, or more frequent dosing can be considered. And then the other thing to consider is it that maybe your vessels are now stiffened up, and maybe it's not responding to medication anymore. And so in some of those cases, we do consider the vasodilator therapy, or vasodilator challenge, where we're going through the angiogram and trying to do an IV vasodilator during the process to see if there's response to the medication.
Yeah, yes, I've had that as well. Thank you.
I have a question, Dr. Kim.
Mm-hmm.
With the extreme dryness of the skin, my hands are always peeling. I've tried every cream on the market.
Yeah.
Any suggestions?
I know it's so tough, because I think that's true. Like, it's a combination of things that leads to the ulcer. It's not just the one thing I find. No, like I don't think there's a magic sort of cream or anything. It's sort of, when I talk to dermatologists, they say, any sort of lotion or cream, and just put lots and lots is what they say. Yeah.
Keeping the skin companies in business, or the moisturizing companies in business.
That's right. The other thing is, I think, well, not in the late stage, but sometimes in the early stage of scleroderma patients can have a lot of itchy in skin, and that can lead to dryness and so on and so forth. In those cases, we do sometimes use very low dose prednisone, or even antihistamine if the itching is leading to the dryness. So even like, over the counter antihistamine sometimes can be used for those cases. But if it's just more pure dryness, that probably won't help as much. I think there's some things right here. The question was best way to prevent an ulcer from progressing. I think so. One is the best way to do that is prevent ulcer from happening. So, once the ulcer develops, then it's very hard to treat, right? And so just making sure that you really don't develop that is really the first thing. As I mentioned earlier, some of the therapeutic options, so some of the medications do help healing a little bit. But like I said, things like bosentan, the studies haven't really shown improvement of the current ulcer. I think that just tells us that once you have a big open ulcer, it's just hard to heal it. So preventative therapy is really where I think we need to focus. Another question, is there anything that can be applied to an ulcer to alleviate pain? I don't think so. I think just like regular pain medication and really trying to treat underlying disorder is really important. There's no other sort of I mean, I'm not a pain doctor, so I don't know. If you go to the pain clinic, sometimes they use different types of pain ointment. But I don't have any sort of expert knowledge on those things. Any other questions?
Dr. Kim, someone has asked, I have calcinosis on my forearms. Where would calcinosis ulcers usually occur?
Yeah, it can essentially occur anywhere, but I would say it happens more so in the area where where the calcinosis gets in contact with something. So like things like elbow or fingertips, or where you're constantly sort of bumping on things. Or number two, where the skin overlying it is very thin, like shin. So shin calcinosis ulcer we see quite frequently. It's not a contact area, but because the skin's so tight over those area and thin, that could lead to the ulcer. There's the published studies. I don't know actually, I think there is, but I would have to go back. I can't quote the published study on sildenafil cream at this point. Not off the top of my head right now. Anything else?
Yeah, Dr. Kim, is there any reason that is known that why I mean, you get the calcinosis in your fingers and whatnot, but also like the liquid calcium, is there a reason why your body just decides to start accumulating that versus?
Yeah, we don't know exactly. So, where in general, so calcinosis in scleroderma or our connective tissue disease seems to be way more than in general population. In general populations, we do see calcium deposits in places sometimes, like if you have a rotator cuff or injury in the shoulders or a tendinopathy, sometimes you'll see calcium deposit. In those cases, we know that calcium usually deposits in the area of damage. We don't know whether that's kind of the same mechanism in scleroderma, but because it's so much more than in general. Yeah. Again, it's an area that's very poorly understood at this point, so we don't have much of an understanding yet. Anything else?
Any other questions? It's 8 o'clock, so I am going to stop the recording now, but you're welcome to ask more questions.